Arkansans Ask is underwritten by the Arkansas State Employees Association, Incorporated, an organization of state employees working toward the betterment of state government.
Good evening, everyone, and welcome to a special broadcast, one we could not have imagined bringing you only a few weeks ago. And that was before what earlier seemed to most people a fairly localized epidemic in distant Asia. Now it's a pandemic, and it's reached every continent save perhaps the Antarctic, and it's reached every U.S. state, including Arkansas. It's COVID-19, a form of coronavirus. At this moment, we can report 62 confirmed cases of COVID-19 in 20 Arkansas counties. Under medical investigation are 146 possible cases. Another 509 individuals in Arkansas are being monitored for possible infection. Thus far, mercifully, no deaths in Arkansas, but the numbers are ever changing. Around the world within the last 24 hours, almost 200,000 confirmed cases and 7,800 deaths. Now that's according to the World Health Organization, and no vaccine. For the next hour, what you need to know about this coronavirus from a panel of Arkansas experts. Dr. Jennifer Dillaha is the State Health Department's Director of Outbreak Response. Dr. Keyur Vyas is a specialist in infectious disease at the University of Arkansas for Medical Sciences. Dr. Steppe Mette supervises the hospital and satellite clinics for UAMS. And Dr. Joe Thompson is president of the Arkansas Center for Health Improvement. And also with us tonight to update the federal government's response, U.S. Representative French Hill of Arkansas's 2nd Congressional District. Thank you all for being with us, and a special welcome as well to our audience on KUAR, Public Radio for Central Arkansas, as well as several other broadcast outlets around the state. We're happy you're joining us. Dr. Dillaha, we'll begin with you. Where do you see the situation vis-a-vis Arkansas right now, aside from the numbers?
Well, in Arkansas, we are seeing spread in communities. With more testing becoming available, I think that we will see additional cases in more counties around the state. So it's going to be important for us in Arkansas to get ready. All our communities, counties need to be ready, as well as our families.
Dr. Steppe, we'll go to you.
The biggest impact for us as a health system has been gearing up to be ready for the potential of large-scale number of individuals that require care. That's been a very interesting exercise in and of itself. We're well prepared for the care that we've provided thus far for patients, but we expect to see many more patients, unfortunately.
Dr. Thompson?
You know, Nick, Steve, this is important because as a nation, state, communities, this is a new virus. This is a novel coronavirus that none of our bodies have ever seen before. So we have no immunity to it. We have no way to defend against it. And so we're using public health strategies to try to slow its spread to keep from overwhelming our healthcare system with very sick people. There are probably three groups. There are asymptomatic people who don't have any symptoms. There are people who have mild to moderate symptoms. And then there are people, as you mentioned, that have severe disease and maybe even, become life-threatening situations. We're trying to slow this spread down to buy time and to buy capacity in our healthcare system, and that's why we're taking such drastic measures across the state and across the nation.
All right, Dr. Vyas.
I agree. Many of your viewers may have heard the term flatten the curve, and that's what we're trying to do. Obviously, we would like to stop the epidemic and have no one else become infected. But with the rapidity with which it's spread and how widespread it's spread and then in the community, that possibility becomes a little bit less likely. So what we're trying to do is slow it down so that we can provide the excellent care that we're used to in this country. What we see in China and in other parts of the world, the areas where the virus hit very rapidly and overwhelmed the local resources regarding healthcare, that's where we saw higher mortality. In places where the spread was controlled and diminished, the healthcare systems were able to provide appropriate care, and we're very good at providing good care, but we don't have excess capacity. We don't run our hospitals 80% empty, and so making sure that we have the ability, that our healthcare workers have the chance to provide the level of care that they're used to providing and our patients are used to expecting, especially in a place like the U.S. where we have very high levels of care.
That term, that phrase, flatten the curve, I guess previously used mostly by professional statisticians, and it's entering common usage now to anyone who chooses. Doctor, we'll start with you. The fear is we haven't even begun to flatten the curve, or am I off base?
It's hard to say. I think that some of our strategies have made an effect, and the reason I say that is because we still have widespread flu, but the intensity of the flu is less now. It's dropped. So we have low intensity, whereas just a couple of weeks ago we had high intensity. So I think the efforts that we are using in Arkansas to prevent the spread of COVID-19 is also having a beneficial effect in the flu. So that leads me to believe that what we're doing is having an effect.
Doctor?
I would agree with that. The statistics of the number of confirmed cases would suggest that we haven't impacted it, but the diagnosis or documented disease is going to lag behind the actual benefit of the strategies that we've put into place. I also think that there's been a pretty good response, certainly in central Arkansas, around some of the strategies, social distancing, making sure that we keep the numbers of people congregating together at a minimum. We've been faster in that response, and COVID-19 has been coming late to Arkansas compared to other regions, which gives me some optimism.
All right, Dr. Thompson.
I think it's important for your viewers, for all of us to know, this is spread by most often respiratory droplets from a cough or a sneeze. That's why having 6 feet away from your next person is your best defense, other than your own hand washing and personal hygiene. I was disappointed when we stopped the SEC tournament because I was looking forward to basketball, and we're not going to have opening day for Major League Baseball. But if you think about it, those are huge venues that you're going to have lots of people together and potentially spreading respiratory droplets. As we have more and more experience and this transmission becomes more and more frequent, we're narrowing that. So now it's less than 500, less than 250, less than 50. Today in Little Rock and tomorrow across the state, closing bars and restaurants where you had lots of communal interaction to try to decrease that spread and to buy us time to build the capacity to treat this disease.
A reminder to the audience, this is your program, not ours. We welcome your questions. In fact, we solicit them openly. The phone number, toll-free, 1-800-662-2386. You can email a question, happily accepted, at paffairs@aetn. We've made a change. paffairs@myarkansaspbs.org. I'm a little bit behind the time. Tweet at Arkansas PBS with hashtag ARAsk. And Doctor, I'm going to give you the last word on that particular subject, on flattening the curve as we began.
Right, and I think that those measures that are put in, which seem very foreign to many of us because we've not had to endure something like this, where forced separation, where kids are not in school in March outside of spring break, those measures where we're keeping people 6 feet apart, encouraging them not to shake hands, the goal of that is to prevent that transmission. The virus is here in the state, and it is spreading, but the further distance we're keeping between groups and out of large groups, that's going to help slow that transmission down, so that we have time to prepare our healthcare workers, to prepare our hospitals, to make sure that we have the resources in order to manage the patients. It's a small percentage of patients that will have severe or life-threatening complications, but if they all come in a short period of time, that can be overwhelming. If we're able to slow down the transmission, then we can help manage and help many more people.
Right. Let me go to Congressman Hill here now, sir. Can you update us on the federal response in terms of resources that have or are about to be, hopefully, made available to the clinical community everywhere, particularly Arkansas?
Right. Thanks, Steve. Well, I look at it as a stool with 4 legs. The first leg was the appropriation of $8 billion, which was for public health money particularly. Our Department of Health got $6.2 million. In that bill, there was money to help stop the disease spread abroad with Americans, so we took both of people at home and people here. And then in the second bill that we passed, it was more geared towards families and our hospitals. There was money in there for the hospitals. There was money for an expanded Medicaid match for the states, so there were more resources that come to the states. There was a way to pay for quarantine expenses, family medical leave for families that are impacted. So if they're off taking care of a child or off on quarantine, their company can pay for that but get reimbursed for it. Those were important steps. The Federal Reserve acted to bring liquidity to our financial markets worldwide so that business would have access to liquidity as the economy has been terribly impacted by this disease. And the final leg of this 4-legged stool is being debated as we tape this show in the United States Senate, where we have additional economic and public health benefits. And this will be geared primarily to our businesses to try to get the capital for a restaurant or for a small business or for a big business that's been impacted like the travel or leisure industry, to make sure they have the resources to keep employees on the payroll and stay fiscally sound.
Well, in terms, though, of federal assistance in terms of clinical supplies, we're reading obviously respirators, a nationwide shortage of respirators is at a minimum feared. But also there is some hospitals anyway. I don't know if Arkansas is, there's some concern about a shortage of masks, gloves, protective garments for clinical personnel, physicians, nurses.
The president announced that he's enforcing the Defense Production Act, which takes executive action to compel the manufacturing domestically of critically needed PPE, for example. He's also got additional money for therapeutics, both in the Defense Department and outside the Defense Department. The FDA is accelerating therapeutics, things like we think of in the standard flu, where you would have Tamiflu might be a therapeutic to ease the symptoms of flu. The FDA today has approved a malaria-related drug that's been off the market for a long time, long-standing drug for use. And the Defense Department has Gilead Sciences on a therapeutic they're testing with military personnel that have the disease. So on PP&E, stockpiles, all that work, the government is mustering its resources to help our departments of health and our hospitals.
On to some questions directly from viewers. And we've already touched on this, but I suppose it's worth doing it again, because it's the most common question to any who would answer. How is this coronavirus transmitted?
So it's spread by what we term droplet spread. So when we cough and sneeze, we expel those moist droplets into the air. Now they have weight to them, and they generally go about 2 to 3 feet. So generally about as far as you can reach your arm. It is not what we call typically airborne spread, where they float for long distances. And that's why maintaining the 6 feet distance, if someone were to cough and sneeze, most of those droplets would fall out of the air. When those droplets, if you were to cough or cough into your hand and touch a surface, the virus can survive on surfaces for a variable amount of time, depending on the type of surface and how moist it is. And so if you were to have a contaminated surface, somebody could touch that, then touch their eyes or their mouth, and acquire the virus that way. So that's what we call a contact spread. So the most common ways that this virus is spread is contact and droplet. So just being in a large room, 2 people far apart, that's not a way that this would spread. But if you're close together in a crowd, then the possibility exists that you could have one of those droplets, or you could touch a surface and then acquire it that way.
I have a sniffle. It's still cold season. I have a flu season. I have a sniffle. Or maybe I have an allergic reaction. At what point do I get concerned enough that I go to my physician or seek professional care? When should I get scared?
So I think the symptoms are important to note here. From what we know about the virus so far, it's a dry cough, it's fever, it's headache, similar to common cold or flu-like symptoms. The recommendations, because we don't want to overwhelm our healthcare system and because in the spread here we don't want to expose more people, is to actually self-isolate at home and see how your conditions evolve. If you've had potential exposure or travel, to go through a screening process, to have questions asked of you to determine your level of risk, and then if your symptoms are worsening, to go on to testing to see whether you truly have a positive test for the COVID-19. But the first step is not to go to your doctor's office, and if you do have advancing symptoms, call ahead before you go so that they're ready to actually treat you effectively and efficiently and keep you from having more exposure under the possibility that you do have COVID-19.
All right. Anyone want to add to that, Doctor?
Yeah, I'd like to add to that too. Dr. Thompson mentioned calling ahead, and that's very important because healthcare workers are at risk for acquiring this disease from the patients they treat. So if you call ahead and you have symptoms that need to be evaluated, whether it's COVID-19 or flu or something else, when you get there, they can put a mask on you, and that will prevent you from expelling those droplets. The mask blocks it. And then the healthcare providers can wear their protective equipment and then put you in a room where they can evaluate you safely without exposing other patients who are there. So that's important, is to call ahead. And also the symptoms that people would want to look for that would guide them to need to go to the doctor are difficulty breathing and chest pain, kind of a heaviness in the chest has been described, and very high fever. They may wish to contact their doctor, and of course anyone having difficulty breathing really needs to go to the emergency room.
A sentiment expressed, or a question, some skepticism, I should put it that way, still broadly expressed. Is the society, the culture, overreacting to this? Dr. Steppe.
I don't think so. If we look around the world and see the impact of the disease around the world, it's pretty easy to see how translating that to the U.S. Would create a pretty significant problem here. There's nothing that is dishonest about what we're seeing around the world. Paying attention to other countries' unfortunate experiences, we ought to be learning from those.
From a governmental standpoint, Mr. Hill.
Well, there's no doubt it's a global pandemic. It's all around the world, and we are learning from the experiences in China, in South Korea, in Italy, and our public health officials are on the phone with those countries daily, learning from the statistics of what's happened in those countries and spreading that information here to prepare our public. And that's why you've seen this as an evolving issue, and I know that's frustrating to viewers, where we go from banning gatherings of 500 to 200 to 50 to 10, but that's the best evidence that we're garnering from listening to our colleagues in Italy or in Europe or South Korea about what their experiences are. And we're getting the benefit of being behind this pandemic's growth to our benefit and preparation, as Dr. Vyas said.
Steve, the only other thing I would add to the comments is we are on the upward part of that curve. We talk about flattening the curve.
Right.
We are just on the upward part. Last week, we had 7 confirmed cases. Earlier this week, it was 20 some odd. Today, it's 62. I will not be surprised if we're in the hundreds by this weekend or next week. And I don't want to panic people, but it's because we're starting to test now. We're starting to understand that the disease is out there. We've tried public health strategies of keeping people quarantined. You can only do that so long and you lose control. It appears we have lost that control and it's out in the community spreading now. So I think we don't know how this is going to play out, but we have to prepare for scenarios that it could be very harmful for a population, very damaging, and that's why the strategies are becoming more and more restrictive of people's movement, which is the primary way that this thing gets spread. And I think that's what I hope your audience understands, that it's moving, and it's moving in a direction that is, we can predict, and that it's getting worse, and that's why some of the restrictions are becoming more significant.
Some numbers we're going to put up in just a second, but let me go back to Dr. Dillaha. It's that exponential nature of it that Dr. Thompson just mentioned that is so frightening to those in your particular, anyone in the medical community, but particularly in your discipline.
Yes, we are concerned about this, and we want the public to take it seriously. This disease has often been compared to the flu, and we can see flu spread exponentially also. However, this disease does not have a proven treatment yet, and we do not have a vaccine, and it would appear that the fatality rate from this disease is much higher than the flu. So we really should take it seriously and do whatever we can to protect the people in our communities who are most likely to have severe disease. That would include older people, people over 60 or so, and as well as people of any age who have chronic conditions. We really need to take steps to protect them.
And some data now that we'd like to cut to up on our screen, and for those who may be listening at home, or maybe once again, as of this hour, and again these numbers are changing literally hourly, but the best we have at this hour, 62 confirmed cases in Arkansas. Now, 6 are children, 15 over the age of 65, 41 aged 19 to 64. Thus far, negative COVID-19 test number 351. To any of our doctors who would wish to answer, it was our understanding that the most vulnerable age group were those 65, 70 or older, and yet we see more cases in the boomer range anyway, or maybe the millennial range than elder. Is that surprising to anyone?
Well,
does that suggest anything?
I think that age range is a bigger age range, so there'll be more cases even if you have the same rate of infection. But also, many of our elderly people have taken steps to protect themselves. And it's possible that many of them are not being tested as the people who are out and about. So there's lots of factors that could explain the difference. And we need more testing in order to really get a true picture of which groups are being the most affected.
I think we don't really know how widespread the disease is, how widespread the infection is, the prevalence. So it's hard to know. And 62 is a relatively small number to make any inferences from, but we are certainly seeing that middle range of individuals, and we're not surprised by the statistics. And from what I'm hearing in the U.S., that what we're seeing here in Arkansas is pretty much represented by what's being seen out in the U.S. and maybe not reported or not initially thought was seen in China, for instance.
We have a question here from a viewer. This is an individual who, quote, absolutely has to travel, presumably for business. What precautions should this individual or others like he, she take?
So I think right now that determination of absolutely having to travel should probably be viewed under a different lens. So absolutely having to travel rather than it would be nice to travel. Lots of people, certainly as the airline industry can attest, have had to cancel and should cancel. So for people that absolutely have to travel, meaning something that cannot be rescheduled or postponed, things that they can do is, again, try to social distance, washing their hands, making sure that they're not unnecessarily touching surfaces, and just continuing to do meticulous hand hygiene. Trying to stay away, keep being aware of people that are coughing and sneezing. But I think the biggest thing is, again, what seemed like an absolute reason to travel 3 weeks ago may not be an absolute reason to travel in these times. One other thing for people to consider is that depending on where you're traveling, you you may either have to be quarantined when you come back, or you may not be allowed to go depending on the country's restrictions, or be allowed to return depending on your status. So I think that we really do need to reevaluate. We're in a new normal during this time, and the old rules don't apply.
Steve, I would encourage folks to explore new strategies too. We're using technology in new ways to conduct business, to have educational activities going on. If somebody feels like they absolutely must have to travel, I would really challenge and say, is there any way technology could help them not have to travel? Because I would imagine the person on the other end of the travel experience that they're going to visit is also thinking, do I have to see this person to get done what we need to have done?
Yeah, I can add to that too. I think people need to be aware of where they're traveling to and what the spread is like there. And they need to be aware of what's at home, so that when they come home, they would need to know, do they need to quarantine or not? But there are means of traveling by automobile, for example, which would be much less risky than using mass transit or some other public form of transportation. So those are other considerations that people could take.
You're breathing fewer people's air
Yes.
in a car than, say, a jetliner.
Right.
And as a regular traveler, I recognize the importance of wiping down the seat table and tray with a Clorox cleanup when you get on board the flight. And for people who are considering traveling outside the United States, I recommend the State Department's website, state.gov, where countries are rated for travel. And right now, as you know, the United States is recommending no travel outside the United States effective today.
Another question. If I contract COVID-19 and recover, can I contract it again a second time?
Well, I think that is an unknown question. We don't know the answer to that. You know, there are other coronaviruses that people get that cause the common cold. Very similar, same family of viruses. And we know that people do not develop lasting immunity to those common cold viruses. So it's very possible that people will not develop lasting immunity to this one, but we just don't know yet. One of the big questions is, can we develop a vaccine that would develop lasting immunity? That would be a big, wonderful, hopeful thing if we can do that. There's a number of companies working on developing vaccines as we speak.
The consensus seems to be, at least from the authorities in D.C., medical authorities in D.C., that we are 12 to 18 months away. Would anyone here dispute that?
For a vaccine?
Correct, yes.
Yeah, there are at least two groups working on vaccines that have started clinical trials. Clinical trials have 3 phases, and it takes a while to go through those phases. First, you have to make sure the vaccine is safe, and then you have to make sure the vaccine works. And they start with a smaller group to see if it works, and then they work through a bigger group to see if it works. And those take time, and it's probably a year and a half away or more.
There was a kind of a wave of optimism. There was the announcement today, or the discussion, I'm not sure how to put this, at the White House, that FDA had approved a sudden, or a well-known, relatively inexpensive pharmaceutical that had proved effective elsewhere in combating this particular strain. Dr. Thompson, there seemed to be some confusion in the immediate minutes after.
I think there is a hope that we will either discover an existing drug that has effectiveness against this virus, or development of a new drug. Historically, the chloroquine family is a drug that has had some success against viral illnesses and was tried in some of the treatment strategies in China. I think that's a hope right now, not necessarily a proven, effective remedy. But I think you've got, as Dr. Dillaha said, you've got multiple countries looking at trying different things. And this is a period of new discovery. Our bodies have not seen this virus before. Therefore, we haven't developed drugs to fight it. We don't have a vaccine on the shelf to pull off and use. So we're going to have to use the innovation of our pharmaceutical industry, the innovation of our clinical communities, to come up with strategies to combat this virus. What we have today is social distancing and delaying communication and transmission of this disease. That is our best tool today as we develop treatments and hopefully preventive strategies through a vaccine in the future.
But Steve, it's good that the government's breaking down regulation and burden and taking some of these antiviral medications that have worked in other circumstances, whether it's against SARS or Ebola or even malaria, and giving people the chance to try those out against this new virus and see what the response is. The sample sizes, though, are tiny.
Yeah.
And I think that's why the medical community is very guarded. We all should be guarded. But I do like the fact that the FDA and our leadership team in Washington's pursuing looking at that approach. Because those therapeutics would be very comforting to people if something works over the next few months. It's not a vaccine, but it's a treatment regimen that could help families cope with this and give doctors some hope on an additional treatment mechanism.
I'd like to add too that it's really important to do the studies to make sure we know what works. It would be a tragedy to put resources behind things that don't work.
Right.
We really need to know what works.
First, do no harm.
Yes.
A number of individuals have written in or called to ask. Most of us will have to, or a great many people anyway, will at some point have to leave. You'll have to go to the grocery, you'll have to perhaps pick up a child or to drop something off to a loved one, if only on the stoop. What can they do to protect on the way back in or once returning home? What can they do to protect themselves, their homes? What products, what substances are effective against this virus?
So the most effective thing that people can do is to wash their hands. As we go, you have to go to the grocery store or to pick up supplies or to work. You're going to come in contact with the environment around you. You have to open doors and touch things as you go about your daily day. But if we wash our hands or use our sanitizer, and then the other thing is avoid touching your eyes or your mouth or your nose unnecessarily. There have been studies that if you look in a group of people, about 30% of them at any given time will be touching their face. And so that's something that we all do multiple times throughout the day unconsciously, but that's also how, if we touch a surface and then we touch, that's how the virus gets in. Being on our hands or other surfaces, that's not causing infection. It's when it finds its way onto our mucous membranes, into our mouth, into our nose. And so between that surface and between your eyes or mouth or nose, if we're sanitizing, if we're using soap and water, that disrupts that chain. So what we learned in kindergarten works. If we cover our coughs and sneezes, if we wash our hands, those interventions are really the simple things that will help prevent the spread and prevent us bringing in not just this, but all the other respiratory viruses that we see. Flu is a problem every year, and many of our citizens die each year from the flu. We have strategies to help combat the flu, which gives us a little bit of comfort. But it is something that we feel a little familiarity with compared to a new virus that nobody has seen before. But the strategies to help prevent them are the same. And so if we rely on the simple, those interventions work.
Steve, I would just add, we're all going to have to get out, to go to the grocery store, to go to the pharmacy, to do required activities of daily living. But we can be smart about that. We can make one trip to the grocery store instead of 5. We can do things, as a batch that minimize our exposure that we have to have. I would suggest to your viewers, anytime they're changing an environment, they're going from one location to the next, find a sink and wash your hands or use some hand sanitizer, because you're exposing yourself at every location that you're going, potentially. And you can take those personal hygiene issues seriously to diminish the chance of you becoming infected, even if you are exposed.
In terms of cleaning our homes or doing what we can to hold down the virus on those hard surfaces or porous surfaces, whatever, what products, what substances are effective against this? We're talking about rubbing alcohol, bleach, hand sanitizer, what?
Yes, those all work. Lysol works. The the important thing is to learn about those products and follow their instructions. So for example, Lysol, you have to spray it and let the surface be wet for a certain length of time in order for it to kill the virus. So, and different products will have different instructions, and people need to pay attention to those instructions. The dilute bleach that people can use, it has to be wet for a certain period of time before the virus is dead. So if you just squirt a little and wipe it quickly, it may not do the job.
All right. We have a map here which could, again, situation changes hourly or at least daily, but we have a map that we'd like to put up now that indicates exactly where, at this hour, the cases have either been diagnosed or individuals are being monitored, or there has been clinical investigation. And I think, as Dr. Thompson indicated, that there's an exponential increase, I think, over the last 2 or 3 days in the sheer number of counties that are involved. If it's not exponential, Joe, it's probably close to that.
You know, this is originally individuals who had traveled and came back with the condition, and then with the health department's good work, there was contact tracing that found people who had been close to those individuals, either through healthcare service provision or casual contact that were infected. I think most of the cases last week and even into this week had some association with travel. What's happened this week, though, is that we're starting to see community transmission without that association with travel. And I think that's where the concern here grows, in that it's not somebody going away and bringing it back now. It's in our communities and it's starting to spread. And that's where you just don't know where you're going to have that exposure, and the potential to get on the upward slope of that curve is real.
Well, let me add too that some of those people who traveled out of state and came back with the disease transmitted it to a large number of people in settings where there were a large number of people around. So even with our, with the current decrease in the number of people, the 10 people gathering, I think that will help, because these transmissions occurred before those guidelines were in place. So when people have traveled and come back, if they're not around those big groups of people, then they're less likely to transmit it to big groups of people.
All right. A policy question, and again, Mr. Hill, Congressman Hill, we only know the parameters anyway, and they're fairly rough, still being hammered out in the Senate anyway on its version of a relief or assistance bill. But a Union County viewer wants to know, is there any indication thus far whether payouts to families will include those presently receiving Social Security benefits?
I think they will. This is probably going to have an income test for families. Individuals making under $70,000 was a number talked about today, so that you could double that for a husband and wife. So say under $150,000, there'd be a payout for each adult and for each child for that family. It would be means tested. It would not be tied, to my knowledge, Steve, to whether or not they're receiving Social Security or not. All that's up for negotiation and discussion. But a key component for this fourth leg of this legislation to help America cope with this virus would be payments to families, and then this, as I say, very targeted lending to help businesses stay in business so people can continue to earn a living.
Photographs on the internet all over in every media of individuals wearing masks. What is the efficacy of that? Is it necessary? Should we be doing that?
So for the average individual in the public, that mask is more comfort than efficacious. It really, the masks have effectiveness to, as Dr. Dillaha said, to contain secretion. So a person that's sick, that's going into a healthcare facility, if we place a mask on the patient, that helps them, those droplets don't spew out, they're contained within the mask. And that helps protect the healthcare workers around them. Within a healthcare facility, for our physicians and nurses and respiratory therapists and all of the people that go into taking care of a patient, if they have access to those masks and appropriate personal protective equipment, then they can lessen their risk to catch this infection. For the average person that's going to the store or just going out, that mask is not doing anything. It's not designed to protect in that environment. When the masks get wet, which if you wear them for a long enough period of time, just the moisture from your breath will get it wet. Once they get dirty, we don't have evidence that they are actually still effective. So the other really difficult thing is that people, when they go and they buy boxes of masks, what we're seeing now worldwide, that phenomenon, everybody is going and getting a box of masks. Those boxes are now difficult to come by for our healthcare workers, where we actually know that they provide benefit. And so, encouraging the public that these masks don't provide protection, and they're really taking away from the supply where they really could be used to much more benefit.
False sense of security.
Yes.
Mm-hmm. So if people have those masks and they don't want them anymore, they are welcome to drop them by any local health unit of the health department, and we'll put them to good use.
Unused, I assume.
Unused.
Okay. If it across Arkansas, many, I think probably the entire state, went into the low 70s today in terms of temperature. Spring is almost here. Is there any basis to the belief that warmer weather will help flatten that curve on its own?
Steve, as I said before, this is a new virus that our bodies have never seen. I think there is basis for hope that warmer weather could blunt the transmission of this virus this spring, but I don't think we have any evidence to say that that is likely to happen, or any reason to not continue the aggressive strategies that we're putting in place to slow the spread down. If it does go away, then you have the question of, is it going to come back next year? And so these are all new, great questions, but we don't know, because this is a novel virus that we as humans have never experienced before.
There is the belief, though, that once the flu season ends in March or in April.
It often does wind down. We see flu all year long, but we don't see the big numbers. And it could be that because school's not in session. Children are just wonderful, very effective transmitters of viral
runny little
illnesses.
noses.
Yes. And so when they're in school and they pass them around to one another, they bring them home to their families, which is one reason why it's a plausible strategy to discontinue school for a period of time. We do that in the summer and flu goes away, so maybe they're related. We have to wait and see. But I think it is important for us to take steps like school closures or restaurants doing takeout instead of dining in, because the more that we can decrease our face-to-face interactions, I think the less likely we'll be able to spread it, and we don't have to wait for summer to come.
A cross-county viewer notes that so far the virus tends to be less pernicious anyway when it strikes children. That adults have a tougher time getting over. What do we make of that clinically? And does this suggest that children are at lower risk than their elders?
So the data that we have available coming out from across the world, it does seem children can get infected with this, but they don't seem to get sick with it to the same degree. So they may have a mild runny nose, or they may not really have much in the way of symptoms at all. But that same virus, if it spreads to an older adult, then that person has a more difficult course. And we see that with other infections as well. There are certain infections that are worse in children and not so bad in adults, but a lot of infections that children and young adults handle relatively well, and we see that with influenza. But and the older adult population is where we see patients who end up in the hospital or the ICU or end up dying from infection, and this seems to mirror that. Young adults can get very sick with it. They can end up in the ICU. It just seems to happen in lower numbers compared to older individuals or those who have other medical conditions.
It would seem to underscore as well, Dr. Thompson, that one of the key phrases here is pre-existing conditions. Children have fewer of them than their elders.
Right. The numbers you put up earlier in this show shows that across the whole age range, we're having infection. So kids, middle-aged, older folks. But for folks, this is predominantly, when it's serious, it's predominantly a pneumonia, a pulmonary event. So people that have pulmonary risk going in are more likely to have problems with the disease itself, or other causes for immunosuppression, like you're on immunosuppressive drugs or cancer treatment, other things that would cause your immune system not to respond as aggressively as it otherwise might.
Several questions about whether it's safe to handle the mail and what precautions should we take. A magazine, a letter, an invoice, a bill? Should we let the mail sit there for a while? Should we disinfect the mail, spray it some way? Anyone?
It's back to hand washing.
It's back to hand washing, and I think that mail being porous is different than a hard surface, the paper. We know that cardboard can maintain this virus for about 24 hours. So if you want to be extra cautious, you can take the mail, put it in your house, and open it the next day. But right now, there's really no evidence that it's a serious concern. So it's a hard judgment call because people need to manage their fear and take steps. And it's hard to have evidence that some of these steps would prevent the illness as much as they prevent the fear.
Steve, this is one of those, just to pivot a little bit, this is where our employers and individuals as employees have some opportunity and maybe some responsibility too. If you're an employee of any employer, you're using the mail service as one, and you've got respiratory symptoms, you need to self-isolate and call in sick to work that day, and our employers need to be supportive of individuals taking those actions. That's how you would have to have a mail carrier actively with disease, staying on the job and delivering mail for the viewer's question to have concern. If we take that employee out of the picture, the concern doesn't manifest itself. And that's where I think employers need to be giving clear communication to their employees, particularly those places of work that have public exposure. If you have symptoms as an employee, I'm going to support you while we safeguard both your fellow workers and also the clients that we serve.
Several viewers, including this one from Grant County, wonder if it would not be a good idea to remove shoes when returning to the home, upon returning to the home, or for, I suppose, even for the office for that matter. Anyone?
I haven't seen anything about that being tracked in on shoes. It's not really tracked in on the dirt. Now, if you're a mom like me, you would want everyone to remove their shoes, including your young adult sons, before they come into the house. So that's one of the issues. But I think cleaning the hands when you come in the house is going to be much more effective in preventing the disease than removing the shoes. But you know, that is a hard habit to get into. I put hand sanitizer in the entry hall of my house on a little chest that I have in the entryway. But it's really hard to get in the habit of using it when you come in the door. So now I've got a little sticky note above the key hole, so when I open the door I see that and it prompts me to use the hand sanitizer. It's those kinds of habits that will make a difference. But the shoes, I don't see that as making a difference. I don't know if other people would disagree.
Steve, I think you've got a good example where there's no evidence, okay, and this intervention, if you will, would be low cost. So I don't think it hurts to take your shoes off coming through the door, but I'm with Dr. Dillaha, 100 times more important to wash your hands when you change environmental settings and to be constantly kind of aware of, are there those people around you that are presenting with coughs or cold-like symptoms that you can put distance between yourself and those individuals.
Quick note to our audience over Arkansas PBS and those entities that are carrying this broadcast. A lot of information to get out, so we're going to go a little bit past the hour, at least a quarter hour or so, because a lot of information we want to get out there. Beginning a moment with this, something that I don't think we've touched on thus far, and that's concern for prenatal care in this epoch of coronavirus. Dr. Thompson?
So I've seen one study that's coming out of China about looking at prenatal or perinatal impact during their outbreak, which precedes us by 2 or 3 months. We're right behind China by 2 months, so there's not been a lot of time to study this. There did not appear to be significant adverse effects on pregnant women during the China Wuhan outbreak. I think that's a cause for us to have hope. I think we still need to support moms or expectant moms, because they are in a transition period with their immune system. So I think high kind of diligence on looking for problems, but I don't think today we have a reason to put them in a high-risk group like somebody who might have COPD or other pulmonary issues that precede the potential infection.
Washington County viewer wonders if taking any sort of antiseptic or applying any sort of antiseptic, for example, swabbing the nostrils with any kind of prophylactic substance, would that eliminate or reduce the chances of him or her contracting coronavirus?
There's no evidence or data to that, that any substance applied in that manner. Sometimes we will look at antibiotics or antiseptics for bacterial infections, but you really have to look at each individual type of pathogen, and there really isn't any evidence that's out there that substances applied like that would necessarily prevent it. Also, again, when we're talking about droplets and spread, when we talk about contact, it's our hands and fingers coming in contact with our mouth or breathing it in. So even if we applied things to the front part of our nose, doesn't mean that we wouldn't breathe them in deeper potentially. So at this point, there is no evidence. There's a lot of things out on the internet or social media about various different things, but there's no evidence that any of those are of benefit.
Go ahead, Doctor.
I would just add, people need to think this through. There is a lot of heightened anxiety that's causing people to search for protections, and there's a lot of noise out there to signal. You would have to know when you were exposed for disinfecting your oral pharynx to even have the possibility of having an effect, and most people are not going to know at what point in time they came in contact with a potential virus. So this is back to, we know hand washing works, we know contact cleaning works, we know that social distancing works, we know that decreasing the gathering size of groups work, we know that travel restrictions work. I would encourage people to know and do what works and what we know works, not get caught up in some of the internet frenzy about, candidly, suggestions that have really little science, if any, and no rationale.
Well, in terms of logistics, Dr. Steppe, you oversee a vast array of clinics and inpatient and outpatient facilities. Is Arkansas ready?
Arkansas is not as ready as it can be or should be. So I think the information is getting out there now, and our physicians are more educated, our clinics are more educated. I want to make sure that the public knows, we haven't quite talked about this, that there are many resources that are available to the public for education, whether it be websites, even for screening. One doesn't have to call one's physician. The Arkansas Department of Health has a wonderful 1-800 number. Many of the hospitals do as well, to get both information and to, if you have questions about your own symptoms and potential contacts, have those questions answered through a screening process. We are more prepared than we were a week ago because of the massive amount of information that is out there, and the policies and regulations that are being put into place. Hopefully we're more ready than other areas have been that experienced the virus before the availability of information was available. But we can't be too ready.
Just in terms of wards, beds, equipment.
We don't know what the extent of the impact of the disease will be yet, so it's hard to know that. If we look at certain countries like Italy, which has been, their healthcare system has been totally undone, it's hard to imagine that we're going to get to that point, but there are some warning signs out there. If we look at New York City, they're hurting. Seattle, the same. Right now, there's a degree of confidence that we are prepared to see an escalation of the number of cases. If we look at worst case scenarios that none of us really want to believe would happen, we probably are not. There are not enough mechanical ventilators in the state to deal with the worst case scenario, for instance. We have an adequate number of hospital beds in the larger metropolitan areas, but not in the small rural communities, which the smaller hospitals really are not equipped to take care of an ill patient, for instance. So there'll be a natural migration of those patients, if they get ill enough, to come to Little Rock or cities that do have tertiary care capabilities. The overall number of beds in the state and mechanical ventilators are not enough. We have a real severe impact of the virus on our health system.
Yeah, Congressman, your thoughts?
Well, I think that's why planning is important, and the hospitals are working together to try to think through that worst case scenario where maybe they would even have a joint facility that they operate and move the sickest patients there so that we don't mix very sick patients in with the general population in the hospital, for example. We've got the ability to muster resources from the National Guard and the military to help, as you've seen in California and New York, where the 2 Navy medical ships will be stationed there to provide additional support. So it's important that we plan for that worst case. I think that's what we're being advised. And we're going to have to use all of our creativity to take care of that. But let me say, if people will go to coronavirus.gov or go to UAMS's website or the Department of Health's website and we all do our part, we can really minimize the probabilities that we would get to that worst case. And that's something that we can all do starting in our family units. And I think all of us together would urge viewers and listeners tonight to strongly reflect about what they can do to help bend that curve, as you say, flatten the curve, but that will allow us to make sure we can really take care of the sickest patients.
Let me stay with the Congressman for just a second and then go to some physicians. This is all over the internet. Is this this particular strain of coronavirus, is this a bioweapon that somehow escaped? Was this manufactured in North Korea? Was it manufactured in China?
I don't believe that. I've never seen anything to that occasion. That is certainly constantly on the internet, and actually there's a 1989 novel about a bioweapon that was invented in Wuhan, China. So the internet's full with that. I don't think that that's relevant to these public health professionals educating our public and protecting our public. But no, personally, I don't think that it was a bioweapon of anybody, and we were all resentful of the Chinese Foreign Ministry last week even suggesting that it was a U.S. Army project. That's preposterous.
I would just say this is something that we have seen happen before with SARS, with Ebola, with other viruses that have jumped from the animal population to the human population that has never before seen that virus. The 2 things that are important is how fast does the virus spread and how lethal is it if you get it. And we're now gaining information about both those pieces of information in new strategies to try to combat this virus. Right. If you were designing a bioterrorism weapon, you would not actually have it become a pandemic because it comes back on yourself as well as other things. Yeah. So I think this is a natural phenomenon that unfortunately we are likely to see additional things in the far future. We need to learn from this one, and we need to get through this together. And I think as a nation, as a state, and in our communities, we're doing a pretty good job of mobilizing to do that.
Doctor.
And I think to Dr. Thompson's point of, we have seen this family of viruses do this before. They're what we call zoonotic spread. They come from animals. There are, probably bats are the initial reservoir. They do have other intermediate hosts, so SARS in 2003, or currently ongoing since 2012, MERS, the Middle East Respiratory Syndrome, that seems to be from bats and camels as the spread to humans. So this, in that regards, doesn't seem to be any different from the things that we've seen emerge before. It just happens to be new, and why it emerged now in that particular part of the world, we can speculate, and we'll learn more as time goes on, but it has followed the pattern of other viruses within that family.
In terms of physical exercise, in terms of our emotional health, I mean, cabin fever strikes some of us. And for example, here's a hot spring, I get Garland County, I assume, individual who wonders if it's safe to go bass fishing this weekend. Let's take the bass fishing specifically. Well, what can we do that's safe to keep the blood moving, so to speak? Anyway.
I think there's no restriction for your individual self to get outside, be physically active. This is not something, today's the first day of spring. It's a beautiful day. We're going to have thunderstorms tonight. I don't know what tomorrow's going to look like, but this is an opportunity to get out and to actually recommit to being out physically active. You mentioned mental health. This is stressful on everyone, whether you're in the work site, whether you're at home, whether you're an employer trying to decide tough decisions about what they do. So maintaining some context to recognize that people are going to react more extremely because they're all stressed, and to recognize this is a unique period of time. And to your bass fishing, my fear is that the only sport that we're going to have to watch this summer is professional bass fishing, because you have two people at opposite ends of the boat. It's
generally stay farther apart than 6 feet. Yeah.
And no audience watching. Now, I love bass fishing, but I'm going to get tired of it if my baseball doesn't come back at some point in time.
Well, I think we can take up bird watching too. There are
bird watching.
Wonderful things that people can do outdoors that don't require them to be around groups of people larger than 10. And, being out in nature really does a wonderful job of reducing stress, and we're all going to need it. So we encourage people to get out and be physically active and reduce their stress.
A Prairie County viewer notes photographs, again, all over the internet, all over various media, of spring breakers on the beaches of Florida or California, maybe Southern California, wherever. And it has to drive a health professional nuts, I would think. Maddening.
Oh, I don't have much that I can comment on that right now.
It's a bad public policy decision. These are making just what we've been talking about. You're making a bad personal decision to do that. It's got public health ramifications, and you've seen cities along the Florida coast react here in the last 24 hours, closing their beaches and urging people to, again, follow these exact CDC procedures. Not to say you can't be outside, right? But it's the social distancing issue of being on the beach. It's not being on the beach or being outside. And I think that's important. I'm glad we've talked about this, because this insistence, be inside, stay with your family, doesn't mean you can't go for a walk. This is a key point, just like you could walk on that beach. But it's about social distancing, and Pompano Beach at spring break is not about social distancing.
One of our viewers in Louisiana wonders, for example, are people with a certain blood type, have they demonstrated or do we know enough to indicate whether they have a higher resistance level to COVID-19 than others?
I don't think we have any data to suggest that a blood type results in any difference in the severity or the risk of acquiring the infection.
And from Benton County, is COVID-19, is it a hybrid, or is this an original virus? It's almost the nature of viruses to mutate.
Yes.
That's at the core of virology, is it not?
Yes, so coronaviruses is a family of viruses, and they're known to mutate and move from species to species. So we know the genetic sequence of this virus, and it's very, very close to the sequence of viruses in bats in China. So we think that's the natural reservoir. So it seems to me that this virus is, it mutated and it moved to humans, and that's a good explanation for why we have it at this point.
Again, on the Garland County question, and there have been several along these lines. Do I, if I have, let's assume that I have COVID-19, or that I don't, is my pet vulnerable? Is my dog, my cat, my domestic?
Oh. I asked our public health veterinarian that very question today, and we have no evidence that it would affect a dog or a cat at this point in time.
A Poinsett County viewer has heard that individuals who are susceptible to seizure are on seizure medication are at greater risk. Can anyone take that?
That is not something that I've seen. Now, it does depend. There are a lot of different things that can cause seizures, and if it is something, say cancer, for which they're receiving treatment and are immunosuppressed, then that underlying condition may, but just being prone to seizures or epilepsy, I don't believe there's any evidence that that increases your risk.
Doctor?
I have not heard of any association or increased risk.
This is where I think you're going to have things that start, rumors, innuendo, whatever, that start to spread. And I would really, as the congressman, I would have people refer back to the CDC website, where the science is going to be presented as we gain knowledge. And if there are associations with certain conditions, I think that's where people are going to get good evidence first. And so I would not turn to Google, whatever your condition of the day is, to see whether it's associated with COVID-19, because I guarantee you'll find a yes site somewhere that has no evidence to support it at all.
Well, a number of viewers have wondered about over-the-counter remedies if they were to be diagnosed. Is ibuprofen, for example, is aspirin, what's effective and what is safe at the same time? Doctor?
So at this point, this concern is coming out from a recommendation put out by the French authorities that ibuprofen may not be safe. WHO has put out additional guidance that says that ibuprofen looks to be safe. I think the original French, what was put out within their healthcare was looking based on theoretical effect on the receptors on cells and whether that would make the disease more severe. There has not been any evidence in any other part of the world that that's the case. And so using fever-reducing medicines, if you're able to take Tylenol or if you're able to take ibuprofen, if you're at home and you've been diagnosed or you suspect this and you have fever and the body aches, those medicines can help as long as you use them according to the directions. You don't take more than you're supposed to, and you don't have a condition, either a chronic liver condition that prevents you from taking Tylenol, or a chronic kidney condition that prevents you from taking ibuprofen. Part of the thing that's hard for many people, whether it's the public or even our healthcare workers, is when recommendations change. But that's the nature of something like this, where the information, the knowledge that we're gathering is evolving so rapidly. We have the ability to learn so much about a new pathogen like this very, very quickly, capabilities that we didn't have 5 years ago or 10 years ago. And so the information, as it becomes available and we're able to analyze it, is likely to change. So that can be a little bit disconcerting, because what we say this week may be a little bit different. It's not because we're making it up as we go. It's as we gather evidence, as physicians and as scientists, we're always looking towards the best evidence, because if you look at just one or two people, something that may look beneficial, these people got better. we don't know would they have gotten better anyway. When you look at 1,000 people, you may see that a treatment or an intervention is actually harmful, things that we thought. And that happens all the time in medicine because we continue to learn and evolve our knowledge.
Yeah. Dr. Mette, a Garland County viewer has some surgery scheduled. Should he or she attempt to postpone that?
What we're recommending is a discussion between the patient and his or her physician. It makes common sense that if a procedure or any kind of scheduled care can be postponed and rescheduled without any negative consequences, that the physician and the patient consider doing so. But we certainly advocate for any care that is required, whether it be a surgery or procedure, a diagnostic test, an office visit, that is time sensitive, whether it be emergent, urgent, or maybe not fall into any of those categories, but where there's some time dependency on success of the therapy be undertaken. And this is best determined between a discussion between the physician and the patient.
Purely cosmetic surgery maybe not the best time.
Steve, I think
Probably not essential.
I think for your viewers, something that we can anticipate and that they should not be surprised by, purely elective procedures, purely elective, dental visits for cleaning, things that consume personal protective equipment. I think we may, in the short run, need to delay some of those so that we retain that protective equipment for use in more urgent or emergent situations. So if an individual that's watching has a healthcare issue lined up that is purely elective, and the provider calls and say, can we schedule this farther out into the future? I hope there's an understanding of why. We're trying to gain capacity in the system, we're trying to conserve limited resources in case we need them, and we're trying to actually, again, practice that social distancing so we do not do things that we don't have to do that increase our risk. So I would just, we're learning, we're gonna have to do this a little bit each day, each week, learn together, but I can anticipate that that's a short-term sacrifice that people may make with elective procedures. I talked to another hospital leader today. They anticipate cutting down on elective procedures now and going to Saturday and Sunday surgeries in the future to catch back up to get people the services and care that they need.
Yeah, viewer Congressman wants to know what you think of the fiscal impact of this on debt and deficit.
Well, when you have a pandemic globally and you have a public health crisis that's taken over the world and taken over the United States, that's unusual. So I don't know that it can be measured in the fiscal impact. I talked about at the top of the show about preservation of our economy. And we're going to
talk about $1 trillion package. I think that's what's coming out of it.
Yeah, so would you like us to skimp on it? So this is the issue of trying to gauge a moving target, just like the health professionals don't know when we'll be through fighting this virus. We're not sure when we're going to be through fighting to keep our economy together over the next few months. So I believe we're going to design a package that can be phased in over months, but be prepared to do what we have to do to keep people working and functioning in this society. It's critical. And this is being done around the world. The IMF today announced their package to help lower income countries around the world cope with the public health crisis and the economic ramifications.
From Craighead County writes a viewer who is a hardy soul, let's say, 77, still working full-time despite asthma and COPD. Should this individual, he or she asks, simply stay home for a while, self-quarantine? Does not indicate whether he or she is displaying any symptoms, exhibiting any symptoms.
I'll jump off. My colleagues, I'm pretty confident, hopefully will resonate. From what we know about other countries' experience, older individuals and individuals with pulmonary conditions disproportionately bear the negative outcomes, including death, from this virus. It's a risk-benefit decision that the risks we know something about. Unless this individual absolutely has to work to survive, I would strongly recommend that they consider diminishing their exposure and staying at home. 77 with asthma, prime target for bad outcomes if they get COVID-19.
Viewer writes, Are we doing anything to protect the prison population? And I suspect what the viewer means is that you get a lot of men and women in very close quarters, like like a college basketball game, and you can expect clinical difficulty.
Yes, we are taking steps. So the Arkansas Department of Health has worked with our Department of Corrections and other agencies to take steps to prevent visitors from, unfortunately, visiting or limiting how they visit, and then screening employees from coming into the prison with illness. So employees of the prison are screened for fever, illness, and if they're symptomatic and have fever, they're not allowed to work that day. So this is to keep the virus from entering the prison, because if it were to enter the prison, then it would be a very devastating situation. The Arkansas Department of Health is also working to prioritize tests from people in institutions like corrections facilities, but also nursing homes are somewhat similar because you have a resident population who live there and can't go anywhere else. And we've taken steps to mandate that visitors be screened, and then the federal government made a mandate that there couldn't be visitors, and then also employees are screened for fever, respiratory illness before they're allowed to come into work.
And finally, we're almost out of time, but this is worth bringing up again. An individual in Benton County, Benton, maybe Saline or Benton County, notes that, as have many others, tens of thousands of people die from the flu every year in the United States. So again, this is another roundabout way of asking, are we being alarmist here? Doctor, we'll start with you. Let's go around the horn.
So I certainly don't think so. As we mentioned, lots of people die of the flu. The mortality, the percentage of people with this virus that die, it seems to be about 10 times as bad as your average seasonal influenza.
10 times?
Yes.
Yes.
So if we think about those numbers, and if we see as many patients with COVID-19 as we do in a typical year with the flu, that number would be devastating. That's why it's critically important for us to do these measures to enforce social distancing, to flatten that curve. We'll bring it back down to that term, back around to that term, so that we don't see those level of numbers. That's why quarantining people that may be infected, or isolating the ones that are confirmed positive, so that we can prevent that spread, so we don't see anywhere near those numbers, because it would be a massive impact, not just on our healthcare facilities, but across our communities.
But higher death rate, but also a more contagious disease than the seasonal flu by a order of magnitude as well, right?
And Steve, I'd go back when we start. This is a new virus that our bodies have never seen, that our immune system doesn't even recognize as a threat. The flu is a virus that is around every year. Most of us have had it at some point, so we may have some partial recognition when we get it. You have treatments if you get the flu, and you have a vaccine that can help prevent you from getting the flu. None of those tools do we have now for COVID-19. We are left with public health strategies of social distancing and trying to slow this epidemic down so that our high-quality healthcare system can take care of the number of people who need it when they're sick, but that we don't have a spike that overwhelms that healthcare system and we're not able to provide that high-quality care.
Yeah. Dr. Steppe?
I agree with what's already been said, so that the real mortality impact could be devastating, 10 times the annual flu mortality, which is somewhere between 30 and 60,000 a year. Multiply that by 10, we're talking about 300,000, 600,000 or more in the United States. And as mentioned, the impact on the healthcare system, not only to manage those patients would be devastating, but the impact on others who have other medical conditions that need to be cared for in the medical system, the healthcare system, would also be impacted dramatically. So yes, we need to take this very seriously, and do all the mitigation and prevention strategies that have been discussed.
Yeah. Dr. Dillaha, the last word.
Well, I think it's going to be very important for all of us to take this illness seriously, and we need to get ready. We need to take steps to protect ourselves. It's like putting your oxygen mask on first, and then we need to take steps to take care of our families, our coworkers, our older relatives, especially those who are going to be isolated, and it's very stressful. We need to help one another, but we need to get ready because this is a very serious situation.
Well, if I could stretch it for just one more minute and get in one last question. For those of us who may have an elderly relative who is living alone successfully, perhaps up to now, how best to go about doing that?
There's some really good
without endangering them.
Yes, well, there's some very good strategies. One is, FaceTime, calling them, interaction. That's really very important. We can go shopping for them, making sure they have their groceries or whatever they need. And then we can make sure that if they're ill, that they receive the care that they need, either by taking them to the healthcare facility or EMS. There's lots of people who've gotten ready for this. Clinics have gotten ready to do telemedicine and not have to have people come in. Pharmacies have done drive-through pickup if you need it. And then our EMS folks are ready to take care of these patients if they need to go to the hospital and don't have another way to go if it's emergent. So there's multiple things that we can do and we should do to take care of our older, vulnerable adults. And I think that if we do that, then we would do better as a society overall. Because if we take care of our older adults, we'll be taking care of ourselves.
And I've pushed it about as far as I can in terms of the clock. Thanks to everyone for being part of the panel. Thanks to you watching on Arkansas PBS or through another venue. Thank you very much for your questions and for your concern. Be safe.
Arkansans Ask is underwritten by the Arkansas State Employees Association, Incorporated, an organization of state employees working toward the betterment of state government.